Hi, it's my great privilege to introduce Will van Derveer, who is a psychiatrist practicing in the Boulder area of Colorado. His organization is called the Integrative Psychiatry Centers. He's been doing work with ketamine and actually giving some wonderful theoretical exposition about the mechanics and understanding of how ketamine works. We were really privileged to have, I think, two presentations at different years of the queer conference that were wonderfully illustrated and dramatic and very thoughtful and different. So it's my pleasure to begin our conversation about our practices, what we think of psychedelic psychotherapy, history, etc. So maybe begin a little bit, Will, with just telling us a bit about your background and what you're up to.
Thank you, Phil. Thanks for the generous introduction. It's wonderful to be with you. Um, so, to keep it brief, I got interested in serious mental illness in college. I was studying anthropology, and I was really interested in how indigenous people use ritual to address significant psychological challenges. And then I ended up in medical school and learning how to use medications and some psychotherapies, but it left a lot to be desired in terms of what kind of outcomes that I could get from just talk therapy and the ordinary medications. And then I got lucky. I caught a lucky break in that a friend of mine introduced me to Marcella and Rick Doblin and invited me to participate in a MAPS study. That was about 10 years ago. So I
Which
got,
study was that, Will?
so it was a phase 2 clinical trial in Boulder, Colorado. We ended up treating 29 people.
Right.
It was a double-blind, active placebo-controlled trial. And, it just pulled the veils off of what can happen when you combine a, maybe not, some people might not call MDMA a psychedelic, but to change consciousness and work with people at the deep level in the subconscious during therapy.
So
So
let's change to some people. And since it sounds like you do, I do. I call it a psychedelic. I
yeah,
call marijuana psychedelic.
yeah,
So I think there are all these classifications that are sometimes they're useful. Useless. Sometimes they're useful. I hate the classical psychedelic one. Classical. Okay.
right,
It's
right,
like Mozart, right?
right. I mean, people are having a subjective psychedelic experience on MDMA often.
Correct.
And so on the heels of my involvement with that clinical trial, I still had a lot of people in my practice who needed help who, uh, you know, I, I didn't want to tell them you have to wait until phase 3 trial of MDMA psychotherapy for healing with MDMA. And I came across ketamine, and that was in 2016 or so. I guess our trial, the paper was published in 2018. So it was kind of a, how do I keep going with getting people a better result um, within the framework of, Schedule 1 and so forth. Um, so we started using ketamine in 2017 with psychotherapy exclusively. And we started with IM, and, we were seeing incredible results right away with some of the sickest, most chronic people in my practice. Um,
Were you
so
using it enveloped in a psychotherapy? How were you?
absolutely. Yeah,
Tell us a bit
absolutely.
about that. What was your structure like?
So my first experience in my practice was giving it to the people who I'd had the most trouble getting well, which kind of makes sense. So the people who I'd known for the first person I had treated for almost 2 decades at that point, and we tried everything under the sun. And that person had a extremely dramatic change. I mean, her Beck depression inventory went from mid 40s to below 10 in 3 weeks. So it was a really challenging integration period to adjust to not having depression after being depressed for several decades. Uh, so so that was my first experience. And
Bit
then,
of a confidence builder, huh?
yeah, absolutely. Absolutely. Yeah. And so to answer your question, that was a person who I'd been doing therapy with for a long time, and then uh, gave it to a few other people who'd been in my care for years, and then started wondering, as people often do, well, is this really just for treatment-resistant depression, or how early in the course of a person suffering would you pull this out and use it? And started broadening the use in our practice. And as a psychiatrist, we usually see people who have already failed 3 or 4 medications anyway. It's really rare for me to see a person who hasn't already failed attempts at treatment. But I think ethically we have to wonder how long should we let someone suffer before we pull out something that's 70 to 80% effective in such a short period of time.
So did you begin to use it first line, as many of us did, and replace, beginning with SSRIs, et cetera, with ketamine itself?
Absolutely. I mean and that's one of the things that's interesting, as you know, Phil, in your practice, that the SSRI is really kind of a mild anesthetic. It helps people cope, and sometimes that's really helpful and valuable. But it also, in my experience, the SSRI oftentimes dramatically decreases the desire that a person has to get to the bottom of their problems. And I think that's a huge liability in treatments with SSRIs. We could talk about other problems too, but the thing that's different, I find, about ketamine psychotherapy is that we're actually going to the psychology to specifically go to look for the root of the problem, in terms of negative beliefs and uh, traumas that have never been talked about or even consciously known. So we're actually giving the person a chance at overcoming the obstacle that um, the SSRI would have them turn away from and not deal with.
So have you felt, as we have, that it offered ketamine in its specificity of how it works, how it's individualized, that it offers a way of developing methodology that embraces it and surrounds it rather than taking just pre-existing and trying to apply it piecemeal. So how has that gone for you?
Um, you're talking about the enveloping around psychotherapy rather
Yeah,
than,
the
yeah.
integration aspects, how you begin, how you end, how you focus.
So the current protocol that we use, right now we have people calling for uh, ketamine assisted psychotherapy per se. About half of our work with people in our clinic are people calling for that. And then the other half of our calls are from people who have had other kinds of treatment failures and they want to do more of an integrative psychiatry assessment and treatment. So looking at gut health, looking at inflammation, looking at hormones, all kinds of potential root causes of this chronic suffering that they've had. So if they are calling for the ketamine and they're appropriate for that, then we'll take them into a preparation phase where we'll have the therapist who's assigned to them will meet.
We just lost you. You froze. Can you hear me? Can you hear me? Uh, you're frozen, Will.
They're about to have is
You've been,
critical.
hold on, you just froze for about a minute.
Okay.
Are you connected on Ethernet by any chance?
I'm on a hard line. So,
Okay, so go back. We'll edit from,
okay. Okay.
we don't know what you said.
Okay. Um,
So you were
so I'll go
saying
to the
about
protocol.
the people who come in for functional medicine,
Right.
but then they may be interested in ketamine.
Exactly. So when we start the ketamine process with a patient, whether they're getting the functional medicine side or not. They start off by doing preparation work with the psychotherapist who's assigned to their case, who will be with them the whole way. And then I was saying that I think it's so important that we take our time to educate the patient about the opportunity they're about to encounter, because I think what often happens if you don't do that is the person doesn't know how to recognize the opportunity. It's kind of like the flight instructions idea that you actually need to be taught how to navigate inside of this expansive consciousness to know where to go and what to look for. So we do that preparation work, and then they have 6 sessions. And we offer, most of the people who work with us have IV ketamine with their psychotherapy. Twice a week for 3 weeks is the typical routine. They may have a couple of more if they're on the road, but not quite there yet. And then we follow up with a number of integration sessions, which are really important for, establishing new changes and actions that will preserve the new normal for them. But we also...
I'm curious, you had mentioned IM, intramuscular, first, and now you've spoken of the IV. How do you choose between them? Why would you choose the IV?
So we started out doing exclusively IM, and it was a way for us to get started that felt less daunting as a psychiatrist to begin with. It's less complicated. It's more accessible. We don't have, outside of your study with Jennifer Duray and Brent Turnipseed, we don't actually have a lot of evidence on IM. There's a lot more evidence on AV. And so what was happening in those early years when we started with IM is we were having a lot of people calling and saying, look, I've done some research on this tool and it looks like pretty much all the research is on IV. Why don't you offer IV? And we would tell them, look, the evidence looks equivalent in terms of IM and IV and efficacy, but the studies are small and there aren't that many of them. So after a while, we decided that we wanted to just try it out and see if IV was any different from IM, since we hadn't had that experience yet. And so then we were doing kind of equivalent amounts of IM and IV. And after a while, it just, because we had the IV set up with the IV nurse and the whole 9 yards, it just became easy to have that be our routine.
By the way, there are people doing huge numbers of IM experiences, like Louis Giofra in St. Louis, who talks of 4,000 IM experiences, but he does no psychotherapy with it. And there are others. So there are people who are quite into the convenience of IM, but aren't writing much about it and aren't enveloping it in psychotherapy. And there's no reason, as you're pointing out, that IV medicine can't be used with psychotherapy as well in the ketamine world.
Right. And it's worked out great for us. We have really comfortable recliners, and the IV pole is behind the recliner. The armchairs, the arms are really high, so nobody can roll out. And our therapists are happy with the IV approach. It doesn't seem to interfere with the opportunity to leave the body and leave the room for a period of time.
What sort of dosages do you use IV?
So our normal starting dose is 0.5 milligram per kilogram. And then our typical routine is to go up by 5 or 10 milligrams per session. I like to follow the literature, and I like to see what looks like works the best. And Lori Calabrese had this great series that she published in 2019 that she presented at the APA, where it looked like about 0.7 was the most effective for suicidality. And we see a lot of people with a lot of suicidal thoughts. So we try to get there. Generally speaking, we end up at about that. 3/4 of a milligram per kilogram. But you also have these rapid metabolizers where sometimes we'll go as high as a milligram or even 1.25.
I think Lori reached that after a long period at zero point 0.5 milligrams because she saw that the power of the medicine was greater, the interruption of consciousness was greater, and she knew that suicidality had to be answered by an interruption in the consciousness that was saying, I want to kill myself. And so I think having talked to her, that was the basis of her increase in dosage, because before that it was zero point 0.5, and her results are much better. You would wonder what would happen if she went up to 1 milligram.
Right, definitely. So, and you're working with the trochees primarily, or I am also.
We do both. So
Okay.
we have we call it trance and transformation. We use rapid dissolving lozenges. We start with a 100 milligram lozenge, have people hold it for at least 12, 13 minutes, and then make a decision as to a higher dose, training them for at-home use. So the 6 sessions are at home. For depression, we have various sequences of how to use it, but we also use the intramuscular route quite frequently, and we often don't start with that because ketamine is such a powerful experience that it's better to ease newer people who have not been experienced into the experience of ketamine by using the lozenges. And because we can do it at home, we increase their agency to do the work with us. We give very limited numbers of lozenges for at-home use by prescription. But the IM we use routinely, and often after the lozenge experience to consolidate a larger ego dissolution out of body experience. And those dosages, it depends a bit on body weight, but more in sensitivity, probably low as 50 milligrams. I have someone who's quite insensitive, but actually has no aftermath, who gets 225 milligrams. But I would say and I have a tiny woman who does 140 milligrams and has no aftermath. So sensitivity to me has always been the issue more than milligrams per kilogram. But the average dose, I would say, is 60 to 70 up to 120.
Okay. And I'm so curious, how do you determine who would do better with a trance versus a transformational experience?
We try to do both.
Okay.
So we're really interested in the so-called psycholytic process, the engaged therapy. But even on the lozenge experience, people have long periods of quiet, but they're more available, and we can do more things like hypnotic induction. We can have more interaction. Pre-COVID, we could have more touching in support, non-invasive. And then the coming down would be more amenable to memory of the experience itself. But we do both. We see them as both equally valuable and employ them differentially. I think you're frozen again. You're frozen. I don't know if you can hear me when you freeze.
Speed test.
Okay, we lost you for about 20 seconds.
Sorry about that. I'm not sure what's going on my internet, but okay. Am I back?
You're back.
Okay.
I hope you feel you're back. You're not a zombie. You remember that Wade Davis book, The Rainbow and the Serpent, on
Yes.
zombies? That was quite a wonderful book on zombies, but you're not one of them. So
Thank you.
yeah, I don't know quite. So I admit I had done my little spiel about equally valuing
Yes.
the trance and transformation, and then you were trying to say something. We don't know what you said.
I think I was saying that I agree with you that there are these, one of the pieces of the art of working with ketamine is learning something you just said, which is that if a person is not able to remain present to the experience, um, they can lose it and have it's sort of like maybe they dissociate too much. Maybe the um, I mean, these all of these experiences ultimately can be valuable depending on how you work with them and how you integrate them. But I noticed that was another, for me, another liability of working with IM was it was so hard to know what the starting dose should be for that person. And
Well, I
typically,
think you could always start. Well, we also do a thing we call hybridization. People have different names for it. So we'll give a lower dose of a medicine, of the ketamine, and then assess the depth of the experience, and then give a second injection within usually 10 to 12 to 15 minutes so that we don't lose the curve of the experience. Um, yeah, and what you're saying is also an important point. So, what is really the relationship of memory to the quality of the experience? Most of us, including myself, don't fully remember ketamine experiences, but as almost all of us maintain during a ketamine experience an awareness of the experience. So it's not that we're not aware in these kind of dosages that we use, and that awareness, I think, is really useful and really the core of the whole experience. So while we do a lot to help people bring back memory, and we titrate those so that we're not obliterating memory as much as possible, yet creating an ego dissolution experience, we've become confident because of our own personal experience and testimonials from all these people we see that the experience itself is occurring and is of value and is so extraordinary that people want to repeat it, even though what they bring back may be attenuated.
right?
And I think that's true of all psychedelics, all major psychedelic experiences. We tend to remember the first one. So, Rick Dobbins fond of saying, well, MDMA it gets weaker. And I don't think that's true. I think what happens is that first experiences are so remarkable and imprint on us so much of an experience that is unique that we hold them in memory. They're like flashbulb experiences. And then the more we do, it's not just that the expectations become more routine because ketamine is always different. Every experience is different, which is one of its great properties. I would say that's true with ayahuasca. So I think that's more of a factor, the uniqueness factor in terms of recollection over time.
I agree. I've been really impressed with how varied the ketamine experience can be for one recipient of ketamine. I mean, it's incredible how varied it can be. And I think the analogy to ayahuasca is a good one there. I think you just don't know what it's interesting how, like anything, a person has their first experience and then they start thinking that that's how it's going to be. And then they have a second experience and it's completely different.
Completely different. Some people have a dark experience, no colors, and the next one is really vibrant and or philosophical or thematic, or you encounter the dead people of your life and you have full conversations. It is really quite remarkable. We have another phenomenon. I wonder if you have it too, and that is people who are less depressed seem to have more vibrant experiences on the average. And people who are depressed may have just as vibrant experiences, but they seem to be less predictably uh, in that kind of intensity. And the colors change as depression lifts. So it's not that people with depression don't have extraordinary ketamine experiences, but it does seem that as your mind uh, becomes healthier and more alive, that the quality and the breadth and the nature of the experience is more expansive. You
Yeah,
see
I
that?
agree. I definitely see that. And I would also say that it kind of makes sense that that would be the case, that folks who have been in chronic brain inflammation or chronic stress, or they've got chronic trauma that hasn't been unearthed yet, hasn't been worked with successfully yet, that they would have a more dulled experience. Um, there's, we know that there's a loss of connectivity between neurons in chronic depression, for example, and with the BDNF impact of ketamine, just on the chemical level, I think it makes sense that would correlate with a kind of more dulled experience in the beginning.
Good.
Yeah.
What other aspects of your practice are showing up as interesting? Teach us a little more.
Well, one thing that I have found really interesting, and there's a personal story I shared with Gita about this when we talked the other day as well. But the phenomenon of very early trauma surfacing with ketamine, perinatal experiences, sometimes material that sounds even prenatal. It's truly it's remarkable that that material continues to emerge in our practice, and we see it over and over again, where early experiences are being worked through, and that's where I think some of the origins of a kind of more maybe anaclitic type of depression, or kind of despair from abandonments or humiliations, severe attachment injuries, arrive, for our opportunity to work through and heal. And it's such a, for me, it feels like such a hopeful phenomenon that a human being in their 40s, 50s, 60s, even someone I worked with in their 70s, can be somatically remembering what the origins are of this chronic issue.
We're up to 87.
87. Wow.
87.
Impressive.
Not too many, but we're up that high.
Yeah. Wow. That's fabulous. I mean, so that, I mean, that to me is just such a hopeful possibility that we actually have a tool. I mean, obviously the world is a really challenging place to live right now. There are a lot of problems. And, as a technician who, or you could say maybe artist or shaman, but as a technician with this tool available to support people to actually get to the bottom of things is really hopeful to me.
So let me explore a different part of it. What patterns do you see that with people where ketamine doesn't work?
Right. There are, we've seen that, of course. I mean, about 1 out of 5 people don't have the kind of result that we see with the other group. So, that's not an insignificant number. It beats ordinary antidepressants a lot, but it's still a large number of people. Sometimes people that have not responded to ketamine have very complicated confounding issues that they're dealing with. For instance, a number of the people who didn't respond in our practice had very unhappy marriages or unhappy partnerships, for instance. Dehumanizing jobs, let's say, or careers, that, living unfulfilled lives, which was a big part of what they were challenged by, and what I think was a cause of their depression that the ketamine couldn't fix, or didn't, inside of their own psychology, wasn't going to change unless there were architectural changes in their environment. So that's definitely one factor. I'm really interested in the anti-inflammatory effects of ketamine in the short term, and what longer term interventions we can make, like changing a person's diet, for example, that can dramatically reduce inflammation in the body that could sustain the ketamine benefits. So we've also seen failures where I think people had so much inflammation going on that the ketamine wasn't enough to turn enough of change without addressing other issues.
In our experience, the people who most frequently don't change are the people who are most obsessionally preoccupied and have the most rigidity to their personality. And even they often have a decent ketamine experience, but what I call the rubber band effect is so rapid and complete that their resorption into their ordinary mind is quick and and so powerful. We have tended to, with a few people, try to keep going where we've had some incremental changes over time with ongoing treatment. But I think that's a larger issue for how do we address, and our field doesn't address it well as at all, is people who are quite obsessional in their core structure. The other remarkable one we've had, which I don't know if you've seen, we've seen a handful of people in the hundreds we've encountered who are not sensitive to psychedelics or differentially. We've seen people who, after being insensitive to ketamine, try mushrooms, try ayahuasca. It's very hard to imagine someone not being able to have an ayahuasca experience. But we've seen a few people who seem to be, and it must be genetically programmed, that within their neurotransmitter world, they don't seem to respond. We've
Wow.
had a few people who don't respond to anything else, but do respond to ketamine. So they've searched and they come back and they have significant response to ketamine, probably because it's an entirely different neurotransmitter system. But there are these poor folks who can't get off.
That's really interesting. I mean, and it's one of the nice things about having different tools with different chemical mechanisms. Uh, I look forward to a day when we have psilocybin and hopefully also LSD and MDMA and ketamine. And I'm curious about your thoughts about, when that day comes. Do you, how do you see these different tools being more effective for very specific challenges people have?
Now, I'm the interviewer. Turning the tables. That was my next question to you. So we can share it. So why did you go first? Because I've been answering this question and dealing with it before. Suppose MDMA becomes legal 2023, Rick is talking about, hopefully end of 2022, and mushrooms maybe a little later, though there's variable concern about when that will happen. And so your toolbox is growing. Now you have ketamine, you have mushroom psilocybin, and you have MDMA. Of course, I don't think we'll see LSD for a very long time. I hope we could standardize ayahuasca so we could do good clinical trials with ayahuasca, and I'm really interested in that. I don't think Ibogaine really coming up too quickly because of its history of hazards, however poorly deserved that may be. So let's say you have those three in the toolbox and marijuana, because I
Right.
think that belongs in the toolbox and is there now. Well, what sort of program would you run? Ha, ha, ha. Don't freeze, don't
Great
freeze.
question. Great question. So, um, you know, I um, I would like to. I trust the long term impact of psilocybin a little bit more than I trust the long term repeated exposure to ketamine or MDMA.
Really?
Um, I think that we have some evidence that mushrooms in general have less of a pro-inflammatory effect than MDMA as an amphetamine. Now, what we've been talking about and what's been researched is just 3 exposures to MDMA, which, and maybe a little bit more exposure. Hopefully we would have, post approval, we would have the authority to actually, treat people who need 6 or 9 or 12 MDMA experiences. And we're not just limited to 3. I don't know how that's going to play out.
Well, we played that out. I would just add, we did that a lot. So we had about 4 or 5 years of experiences of very intense MDMA, even MDMA and mushrooms together. And we didn't have ketamine, but we had a lot of experience around that, and it was good experience. It was not bad experience at all.
Yeah. I mean, I think that there are cases of PTSD where someone's going to need more than 3 sessions. That's very clear in my
Well,
mind.
many of the people in our phase 2 study of life-threatening illness wanted to go on and have a 4th or even a 5th session.
Hmm. Absolutely. Now, I think that uh, I think if I have a person with severe PTSD, based on my experience with MDMA, that's my tool of choice, because of oxytocin, because of the direct impact on fear, all the reasons, and the durability of what we're seeing in the long-term follow-up studies is incredibly encouraging with MDMA. So I think that's still my first choice. Now, for PTSD. To me, where it gets a little bit more confusing is whether I would choose psilocybin or ketamine for chronic depression. The the preliminary evidence on psilocybin for depression is incredibly encouraging in terms of very long durability after just one exposure to psilocybin. I guess my bent is always toward using the least amount of medication possible to get the biggest impact. And so, if a person needs to eat a mushroom 40 times in order to get the result, if I had to choose 40 exposures to psilocybin versus 40 to ketamine, I still think 40 is in the realm of relatively safe with ketamine. But, we do have concerns about very high, very long-term exposure to ketamine in terms of, the bladder and so forth and so on. And I don't think we have any concerns about long-term exposure to psilocybin that I've ever come across of
But
any
we
kind.
do have very long-term exposure to ketamine information now. At the lower dose levels, we're not talking about street and high dose over time,
Right.
or even in the clinical situation. It's pretty infrequent that people are doing it daily, even at low dose. Though there's a lot of analgesia literature on daily, 3 times a day dosage. So I would take a little disagreement. I think the ketamine in our hands, and we've been at it for 5 years. And we've had a bunch of people who are on maintenance and who've used it, probably 70, 80, 100 times. I know lots of people personally who have done that over decades. I think the issue is integration, more than the frequency of it. So how you put it into a program, to me,
Exactly.
is clear. So I agree. Psilocybin mushrooms seem to be as safe as anything that we can think of. But in general, MDMA has truly been a very safe substance. If you look at the tens and tens of millions of
Oh, sure.
exposures, the safety of these things is great. And ketamine, without any respiratory suppression, used properly and intermittently, is truly safe. We just finished a study on uh, ketamine in breast milk, looking at how quickly ketamine would elete from breast milk and how quickly you could expose a neonate to resumption of breastfeeding. It's a very quick metabolism. It's 2.1 hours and 1.2 for the norketamine that's somewhat active and not particularly active, and we don't know much about it except in rats. So I think in proper hands, with all our people, we haven't had a bladder problem. We've had two people who thought they had a bladder problem and didn't have a bladder problem. And sometimes what happens is you have a urinary tract infection that
Right.
seems to be a bladder problem. So the safety issues in proper hands, even at home, people are afraid of home use. We've had wonderful experience, and it reduces the cost of treatment enormously to be able to do it, as long as you're doing it thoughtfully, with connection, with supervision. So I don't know, it's interesting because I'm older than you, and I've watched, this process of use underground, I call it the ground, over 5 decades, and I wouldn't be so sanguine about psilocybin over time. I think psilocybin experiences are remarkable, but I'm not so clear about them being a rescue from PTSD in the same way as the Hopkins report, nor that one session is enough. It's just not what I've witnessed over time. And
Mm.
I think really when you look at the population outside of clinical studies and outside of, and even if you look at the practitioners using the medicines who are more experienced in general than they're alluding to in terms of what they're reporting in their studies, you see a large number of experiences that people have had over time, and that it's part of an overall kind of psychotherapeutic life strategy in which substances play a major role in the evolution of consciousness, behavior, help with relationship conflicts, help with downs, help with trauma. And as you said earlier, this is a time of terrible trauma, and our resources are minimal to address it. We're trying to do that with what we're calling the sharing group within our organization, and I wish we had more availability of trained psychedelic psychotherapists to do this work. It would be a great
Right.
help in this time to
Right.
bring people closer. So
Well,
I think the clinical world and the street world, which is the wrong name for it, the clinical world and the ground, the core of voluminous human experience, they're somewhat at odds with each other
right.
because of the strictures of one and the lack of strictures or information of the other. But there's so much information.
Right. I mean, you're speaking to another piece, which I think is, again, the enveloping these catalysts inside of a
Mhm.
deeper psychological inquiry is so critical. And uh, there's just a lot of misunderstanding about that, not just in the lay public, but also in the medical establishment, about this massive opportunity to actually take a look at the structure of yourself and your personality that comes with uh, these incredible tools.
Well, it's
Uh,
a revolution in our field, don't you think, to go from suppression. Most of what we do is we suppress. We suppress hallucinations. We suppress delusions. We suppress manic behavior. You know, the uplift part of our work has always been the smallest part, and often not even within our framework. It's been outside of our framework. And to have this switch, this dramatic kind of, uh, it really is a paradigm switch to where we're saying to people, you need to have pleasure. You need to get out of anhedonia, not just by taking a drug, but because of consciousness, because of your connections, because of your life. And here are substances that are sometimes quite difficult. They're not so easy. The powerful experiences they engender can be really quite troubling and take time to integrate and need support and need good set and setting. But they're there and they change the whole nature of what we as practitioners are offering. And so to bring everyone along, I think we're doing pretty well. We got this whole week coming of bringing people along.
well,
You're
that
bringing people along. We're doing
well,
pretty well of getting there. And
well,
we've had stalwarts in it. People
well,
have
and
persisted.
I'm grateful for our ringmaster. Uh, you're quite magical in your ability to sort of call forth this kind of merry troop of uh, revolutionaries. And it's really good timing the K Dome right now for the virtual Burning Man right now, because there is this, I feel like this swelling up in this revolutionary cultural revolution feeling happening right now. And why shouldn't mental health?
You froze again. You were at a good point too, and you froze again. Uh, well,
Need in order to accomplish that
you
transformation.
froze at why shouldn't. So,
Darn it.
so why
So
shouldn't?
why shouldn't psychiatry also be revolutionized at this moment in time, where we need to overthrow the old suppression model and replace it with an evocative, life-affirming, pleasure-affirming model?
And trauma treating. I mean,
Yes.
really, we have to help people in the larger sense deal with all that's going on, the murderousness, the racism,
Yes.
the COVID, the deaths. I mean, really, we're not even addressing it. It says as if it's passed over. 180,000 people in this country alone have died of COVID, and
Well,
we're playing a game with it as if no one's lost anyone, and they're all
right.
older people, so it doesn't really matter.
Right.
And then global climate change. I mean, we really have to help people come together, including ourselves, to converge in terms of sharing both our pain and our suffering and generating a sense of support and optimism, or else, you know,
Yeah.
people are wrestling with what's the point? I mean,
Right.
it's all screwed up anyway. So why should I bother? But
Right.
I think a lot of us don't feel that way. We think that our life is engendered by meaning and by connection, and that's what we're going to support. And I love it, and sharing are the ways to do it. And it's a crucial time.
Well, and that chaos can be a good thing. Ultimately, it shakes up the structure and makes room for change. And there, you're right. I mean, the conversation about trauma is not happening, and probably never has happened enough in anywhere in human history. But at
Yeah.
least now we have a lot more understanding of what goes on in the body, how to heal it. We have technologies that work, and so
We have brotherhood and
yes,
sisterhood.
community, right? Exactly.
That's a good part of this K Dome thing, and of coming together and transcending some of the silly kind of boundaries and territorialism that occurs between practitioners, or who's got which better drug, and my drug's better than your drug,
Right.
and I'll show you my drug's better than your drug.
Sure.
All of that kind of crap.
Mhm.
It's hopefully we can dissipate that, really.
Well, it's and especially if we're trying to accomplish massive change in the world. I mean, we we can't waste time in these sort of sideways conversations that can happen.
Yeah, and the truth is, all of these drugs are often drugs. They're part of the commons. There's almost nothing that's brand new out there. MDMA is 1912 or 14,
Right.
and mushrooms grow in the ground, and ayahuasca grows in the ground and up in the air, and
Right.
these are part of the commons. The argument over what do we really own as a people with nature. We own the air.
Right.
We own the water. And we own these substances by and large as well, because they're part of our lives. They grow, they're orphaned, they're not private anymore. So it's an opportunity to enlarge the sense of we are the owners of the things that transform our consciousness.
You know, I'm wondering about a few minutes ago, you said, we need more psychedelic psychotherapists. And I know that, you've trained a huge number of people. Uh, and I'm curious your thoughts as we look ahead to MDMA and psilocybin. How are we going to meet, how are we going to deal with the bottleneck of not having enough people trained well?
You and I and others are going to form better and better associations with breadth of argument and disagreement, but basic unity about what's good for people. And we're going to keep growing and growing and growing. We're stopped by COVID right now, but the more we can create organizations of, that are voluntary, collaborative, and cooperative, we're going to bring a lot of people in. There's so many people who want to learn how to do this. So many people want to take shortcuts. And
Right.
I'm not for shortcuts because I don't think they work. And you're not for shortcuts. You're doing a very developed, thoughtful way of approaching humans. And I think we need to set the best practices standard of care model. We're not going to stop commercialization or
Right.
competition, but if we have sui generis, a basic practice model that says, here's a range of what you can do with people that's really useful. And there are many technologies and methodologies, but here are the good ones. And
Mhm.
here is how you treat people ethically. And here's how you don't violate people's privacy or their sexuality or things of that sort. I think we can do that.
Yeah.
We're not going to stop all the vagaries of the mess of it, but I think we have a way of expanding it. And I thank you for today, and I really appreciate it. We'll probably get rid of your freezers, although you're cute when you freeze. You're quite cute. So
Thanks, Phil.
we'll look at that, and we'll see you in the infinite. In the Infinite Playa in the Cato Microdome. You got a bunch of stuff.
Look forward to it.
Good to have you and Krista.
So good.
And
So good. Thank you so much, Phil.
thank you.
So grateful. Take good
Thank
care.
you too.
Okay. Talk to you soon.